I'm going to speak a little bit about some work we've done, very preliminary work on BCI and the concepts as we see them in the earliest stages. Here are my co-investigators. One is Arjan Ahmadpour, University of Chicago neurosurgery resident, who's done a lot of work in this area as well. I have no disclosures. This project was funded by NICO Corporation in the NorthShore University Health System. So just a little bit about what I do. I'm the chairman of the Department of Neurosurgery, NorthShore University Health System. We're the largest academic system in Metro Chicago. We cover 10 hospitals. We have 20 neurosurgeons, 15 PM&R physicians, 3 comprehensive stroke centers, 3 sites for advanced brain surgery, Evanston Hospital, Edward Elmhurst, and Northwest Community Hospital. Many of you know of or know Amin Qassam, who was really very instrumental in the early phases of developing the 6-pillar approach. And many of these principles we're talking about, he has started to head up Northwest Community Hospital, which is a 550-bed hospital in Arlington Heights, Illinois. And we have a North Shore Research Institute. We have, in our department, we have a R21, we have an R01, we have industry grants. So we're pretty active. And there's my contact information if you want to follow up with me or give suggestions or ideas about how to make next year, the 10th meeting of the SSG, better. Some of you are probably not surprised to know that Elon Musk said several years ago that by the year 2020, he would have your brains all connected to a computer. And I try to figure out why that didn't happen. Maybe the Twitter stock scandal and price drop has got him a little preoccupied. You know, his company you see on the bottom left there, Neuroline, is sort of reminds me of an old sewing machine bobbin, I think they called it. I remember my grandmother having one where the thing goes up and down and kind of knits very superficially, connecting threads. The question really is, you know, despite single electrodes or grid electrodes and surface connectivity, is there a lot more and better real estate deep in the brain? And it consists probably about 99% of the brain architecture is, of course, internal. So that's where I have to question where this maybe could go, should go ultimately. And I hearken back to the development of the microprocessor, right? We all know this. In 1971, the Intel 4004 had 2,300 transistors, and you look down to Apple's new M1 Max has now 57 billion transistors, 10.4 trillion floating point operations per second. And so thus we've seen in summary, a billion times increase in computer power in 50 years. And you see there on the right, Andrew Grove, Robert Norris, and Gordon Moore, who were really the pioneers in this advancement. So what do we have to work with? What can we as an SSG begin to look at? And this is the basic principles. Of course, we've talked about them and we all pretty much use them. We use white matter mapping, we use navigation, we use optics, we use a brain path subcortical access. We have resection tools that are single shaft endoscopic tools. But the 6 pillar is something we've always had a great allure and interest in. We just haven't really perfected it yet. We didn't really know where that was going to lead us. But this slide's 10 years old. And of course, we have experience replete now with very good access to the center of the brain, as I like to say, the last organ to be internally conquered in the human body. And we've shown how we can successfully remove things, take bad things out. The question is, what can we put back in? You'll hear a talk from Dr. Chen later about putting back cesium-131 gamma tiles. And we've thought for years, is there regenerative medicine? Is there stem cells? Is there pharmaceutical agents? Is there other aspects and molecules that could be placed or left behind? And we heard about that a little bit yesterday with the Enrich Plus study, not so much placing intracavitary, but in that case, an oral drug. And then we'll see what we can come up with later. So the science of neural interface engineering obviously is way beyond this conference and my expertise and our experience, but suffice it for realizing that there have been many advances in material science, mechanical, electrical engineering, nanoscale fabrication, and that all underpins the progress which has brought us to this point. You see on the bottom right, you see a Utah array on the left side of the picture. On the cortex, you see electrodes and you see grids. But we must consider not only surface and very superficial areas, but also three-dimensional volumes and deep aspects. So the development of these materials, which couple electrical, optical, and thermal input, all are going to be a big part of functionality. The boundary and the electrochemical reactions have yet to be fully figured out, of course. We think that noble metals, as you see here, platinum, iridium, gold, and their alloys have been believed to be the right elements to use, of course, along with silicon. But we really have to look at things with low impedances, high charge capacities. And there's engineered material structures, there's optoelectric, electronic, neural interfaces. All these are aspects which have to be factored in. This is a recent article by Martini et al. In Neurosurgery, emphasizing the sensory component alone is critical for BCI circuitry to take effect. And of course, there have been for a couple of decades efforts at putting surface electrodes for paralyzed patients. And just like the example of when you cross your legs and your foot falls asleep and you go to stand up, you no longer have the proprioception of the position of your ankle, and you can't walk, even though your motor may be fine. So, everyone knows the pressure of the chair on your rear end right now. You know the position of your right ankle. You have to know that. You don't think about it until I call it into consciousness, but you couldn't stand up and walk out when the break happens if you didn't have all that input constantly occurring. So there have been, of course, different efforts. One of the most exciting is Synchron with the Stentrode, which is a transvenous placement of an electrode that just got approval for clinical trial by FDA. And what that does is supposed to sense motor cortex signaling for paralysis and placed in a transvenous non-invasive method. So our real interest was, what about harking back to Gordon Moore and Andrew Grove and Robert Norris? What about the power of the IC, and knowing that it probably one day is going to be more than an electrode, a blind electrode, a static electrode, passive electrode, or a single stimulation electrode. So this experimentation involves 17 adult rats. Burr holes were created bilaterally near the bregma, right in front of what best we could tell in our rat stereotactic axis atlas was the SMA. We had a modified miniature NICO brain path tubular retractor with a stereotactic head holder inserted through the burr holes. One side served as a control and the other side served as the implant. In conjunction with Dr. John Rogers at Northwestern University, who has a 100-person laboratory and biosciences effort, he chose these two ICs of different sizes. They were passive chips. They were not connected to anything. They were nickel tin alloy contact leads. And we were trying to address two issues. One is, can we and how do we insert an IC in the subcortical space? And then secondly, did that kill the animals? What was the foreign body reaction? What was the result of doing that? So here's the process here. You see the vertex incision. I think you can appreciate bilateral small burr holes created with a small drill. You see the size of this is the small integrated circuit. You see it in the upper middle panel there. The black dot, which is in contrast against the gauze. And you see the progression of placing the modified NICO brain path rodent port into the frontal lobes. The insertion was facilitated by something called cerebral nutrient factor, and that is a dexahexanoic acid DHA based material that also has antioxidants in it to facilitate not only the safe and accurate placement, but also hopefully reduce the foreign body reaction. Here's a video showing that technique. And then the obturator or sort of plunger is placed secondarily on top of that to allow, can you back that up and maybe we'll play it one more time? And that obturator allows us to deploy and have the small IC stay in place. Otherwise it would, with surface tension, tend to come out. So our results are that the chip placement resulted in a track that maintained, as you can see here, upper left side, and you see a fairly gliotic cystic cavity track, as you would expect. There's a cellular aggregate at the bottom of the track, as you see in the panel on the right, and here you see the results microscopically, and you see the evidence of the microtome transecting the IC. The IC was so small we could not see it, and we weren't able to avoid it for a microscopic examination. We transected it. We see hemosiderin-laden macrophages surrounding the black remnants of the microchip. Our results were that there was no mortality. All animals recovered normally and were sacrificed at 1 and 3 months. There was no evidence of infection, wound healing issues, extrusion of the IC, and they all were graded normally by neurological examination. We could see the insertion track bilaterally. GFAP staining showed the presence of reactive gliosis, scattered CD3 positive lymphocytes, CD68 positive macrophages and monocytes. However, there was no significant scar formation either on the chip remnants or along the bed of its implantation. Our conclusion is that it's technically feasible to insert an integrated chip subcortically with modified delivery systems, with limited scar formation, and with animal survivability. So this is obviously a very early study, and the first that we're aware of to technically modify delivery systems for placing an object such as a small IC in the subcortical space. There's a lot of issues, as you see here, concerning what's currently on the market, whether they're therapeutic or diagnostic, and how this may fit in. The future of BCI, some people say, is enhanced cognition. A lot of work yet to do. This was a feasibility study, and hopefully will pique your interest and demonstrate that the subcortical surgery group is always trying to broaden the frontiers and look at how we as surgeons can be involved in the science of BCI that goes far beyond just our technical abilities. Any questions or comments? Okay.
Really, really nice work.
Thank you.
it seems that you're implanting a IC that's disconnected from a power source. That's what, and do you see this as a independent unit in the future where it powers itself, or how do you see this independent unit communicating with, you know, the an external sensor or where the power source might come from?
Yeah, great question. You know, power and connectivity are going to be two of the main issues. It's like if you think you're going to design a robotic system for surgery, you've got to think of the effector arm, what does the work, the optics, the eyes, and the brain. For here, it's going to be how you could how it integrates, of course, and then as you so aptly asked, you know, what's the power source going to be? Is it going to be rechargeable? Is it going to be long acting? And how do you connect it?